outset, I would like to thank Dr. and the whole organizing team of Ahmedabad for this rocking conference. And also, I would like to thank the scientific committee for talking about a less discussed complication. I think running 7 halls on 4 days, it has been incredible. The discussions have been very good. Let's talk on some less discussed complication. We used to talk about, or what we teach in most of our teachers, the microvascular complication, the macrovascular complication, how much we talk about the skeletal muscle in diabetes. And now, yesterday I was sitting in one of the hall talking, there was lots of discussion going on as GLT2 inhibitor. Then they came, muscle chali aati hai. Then they came sarcopenia. Yes, it's not the drug, yes, the disease itself. And we need to be aware about this less discussed complication. And at least the physicians, the metabolic physicians should be aware about it. And just bedside tests. You can just assess sarcopenia when the patient is walking in your clinic, the time he is taking to get up from his chair. You can use certain questionnaires and you can see about this complication when ignored, that has its implications. But if it's detected early, yes, you are able to do, because there's not much in treatment point of. If this is where the preventive role will be there. So, diabetes and sarcopenia are cannot move. So, by definition, there is a definition was given in 2008. It's a progressive and a generalized skeletal muscle disorder that is associated with increased adverse outcomes like fall, physical disability, and mortality. See, there is loss of muscle mass. There is loss of muscle strength. We say that is like after 10 to 15 years now, I'm having drained, I'm fatigued. Yes, you should be careful about it. Most of the chronic conditions, chronic disease, aging, there is decrease in the muscle mass, there is a decrease in the ability, but this diabetes, this makes it more progressive. And yes, this is an entity. There is various societies has given the definitions of sarcopenia, which is on the basis of low muscle strength, which can be assessed using the hand grip dynamometer. There is a low muscle mass, which can be assessed using the DEXA scan, the body composition analyzer, the CT or MRI, which can be used for assessment of the axillary appendicular mass, the poor physical performance, which you can assess in your clinics by assessing the gait speed. The patient walking from a 6, just start a timer and see how much timing he's taking, and just divide the time. You'll be getting the gait speed. You will be able to assess, yes, this patient, not only Parkinsonism, our own diabetic patient without any higher mental function problem are also having this. Now we have the diseases. There are two parts of the coin. If you see sarcopenia, where we talk about the muscle is weak, there is muscle mass is less. The muscle mass is less, but they are obese by the criteria of the BMI and the waist circumference. There is a word called sarcopenic obesity. There is obesity, the visceral obesity, and there is sarcopenia. So there is muscle mass is reduced, but there is skeletal muscle loss. But yes, there is abnormal and excessive accumulation of fat. So now this is a problem seen in our diabetic patients. There is decline in the muscle mass strength and the performance. There is low expenditure, insulin resistant inflammation by the virtue of diabetes and the metabolic syndrome resulting in sarcopenic obesity. It is considered as, it has been designated as an ICD score. So yes, it is a disease. There is a progressive muscle loss across the age. We expect after age of 30 or 40, there is per decline of muscle mass around 8% if you are not exercising. There is the role of prevention. In your 30s, in your 40s, advise your patient to do aerobic exercise. Do resistance exercise at least 3 days a week. That is going to save you in the future. exercise kar lo, budhapa nahi aayega, I say. So this is very essential, because until 70%, the 15% of the muscle mass is lost. What are you going to do in your 60s? So start doing that in 40s. Then the thing is already, the ship has already sailed. Yes, this is the classification. This is a disease which is a known age-related muscle loss, age-related muscle atrophy. But now we have secondary sarcopenia. There is a, which is nutrition-related, disease-related, activity, physical inactivity related. If you see the prevalence, so you see only 10% are affected to the global range of around 50% or severe cases of 2 to 9%. This can be prevented if we talk early, if we discuss. So that is the what the today's symposia is. Let's discuss topics. And I am thankful for keeping this topic in discussion. So, and this is like, this was compared with the complications also. You see, with the other diseases also, the cardiovascular disease, the dementia, the respiratory diseases. So the prevalence is more common in the diabetes and the cerebrovascular disease subcohort. So we see the prevalence is rising. There are increased risk of all-cause mortality, there increased risk of cardiovascular deaths, higher risk of fractures, and obviously the tendency to fall, the frailty. So there is a society of international society which has given the guidelines of frailty and sarcopenia. We'll be having their guidelines in the presentation. So it is this sarcopenia is a potential cause and consequences of type 2. This is one of the study which was published in the underwent in the Australian population, and it was published. Here they have an bi-directional relationship. They have they have both consequences and cause of type 2 diabetes. So where the patients, low BMI patients, so we always stress on extremes are abnormal. So it is the middle path which is always good. So you see, the low muscle mass, the low strength, they are increased risk of type 2 diabetes. Whatsoever be the reason of diseases, sarcopenia, and the presence of type 2 diabetes, this exacerbate the progression of sarcopenia in older adults. This was one of the newspaper cutting. This was published in the newspaper. This was the AIMS study. So the last 2-3 years, there has been lots of data. Dr. Naval has been instrumental in doing this study in the center in AIMS, where he was the principal investigator, and he found the prevalence of increased sarcopenia in his subgroup of population. So sarcopenia, obviously we have lots of literature, the Western study published by Dr. Abhay Sabu. So there are, people are talking about it, people are evaluating it, and we need to put it clinical practice. That is from the desk to the clinics. That is what is more important. So we have to talk about the metabolic syndrome, the inflammatory conditions, along with the extremes of malabsorption and malnutrition, contribute along with physical inactivity contributing to sarcopenia. So we talked about the bidirectional relationship of the diabetes and sarcopenia. So skeletal muscle, yes, this is another site, one of the octet which affects the D-Franzo octet. So this is responsible for 80% of accumulation of or utilization of glucose in type 2 diabetes, and insulin resistance impairs muscle glucose uptake and metabolism, reducing muscle quality. So there is a vicious cycle between sarcopenia and type 2 diabetes. So we see there the potential therapy, the myostatin messenger RNA expression. So this could be one newer modalities of treatment, which should be protein synthesis. So now enhancement, because there is no such treatment protocol in this space, in this subgroup. So in enhancement of good high quality protein intake is one stay. Increasing the physical activity, another. Certain biomarkers are there. So we are evaluating and looking at the pathophysiology, and futuristic we are hoping for some treatment to come for, but till it we need to do something on the preventive basis, and awareness is one where we need to hit. So we talked about the insulin resistant and the process by which they may be associated, or they may have a causal association with type 2 diabetes, and this may be observed decades before the beta cell failure and hyperglycemia develop. So it's not a late complication, it is an early complication. This we should remember. So the impact, it obviously the morbidity, the quality of life is affected. There are various complication, the operative complication, the longer hospitalization. The most common is the falls and fractures, which we do talk about in earlies. The metabolic disorder, cognitive impairment, mortality are the other things. I was there in one of the SGLT2, because now we are having lots of SGLT2 in the market. So I think wherever I sat, there was so much discussion of SGLT2. The patients on SGLT2 and GLP-1, वो तो body weight कम कर रहे हैं. That is by the virtue of this they have ascended in our armamentarium as a first line drug. But वो muscle mass भी कम कर. There are very conclusive data. We don't have much data whether the muscle mass is being affected, and there are lots of literature that it is not. The drugs are not directly responsible for muscle loss. You can, because these drugs have to be initiated the metformin in the initial stages of your treatment. So don't worry about the muscle mass. You combine it with your exercise, which is the MNT, and you may not have loss of muscle mass in your treatment. So what are the assessment tools? There you have to look for the muscle strength, the hand grip strength, the physical performance, as I talked about, 6-meter walk, or the repeated getting up from the chair test, the appendicular skeletal mass by using the other scan methods. It's an early diagnosis and management of diabetes can help in prevention of sarcopenia. So diagnose the patient is vulnerable, he is thin, low BMI, he is elderly in age or a middle age and looking towards having a features of sarcopenia. You control his diabetes, manage his diabetes in a good manner, advise him lifestyle modification, and yes, we can help him out. So what the guideline says in the diagnosis, any elderlies of 65 years of age should be screened for sarcopenia annually. They have to be looked for the gait speed, or there is a SARC-F questionnaire. The other questionnaires, the 5 questions you can ask the patients, and they can confirm sarcopenia. The confirmatory can be like the diagnostic criteria, the DEXA scan, or the CT, or the MRI, or the body composition analyzer which you have. The walking speed or grip strength, which can be done by a handheld dynamometer. The screening tools of the screening, these are the, I was talking about various screening tools. The SARC-F, which is one of the popular tools, there are 5 queries every 2 questions, and cutoff points are more than 4. So the SARC-F, I'll just elaborate a bit. They have 5 domains. Yes, strength, all the 3 has to be measured. Assistance with walking, rising from the chair, climbing stairs, and falls. So they are not, there are certain questions you ask, they grade them to 1 to 2, and you see the score. The other score is MRSA, where you see the age, the number of hospitalization, level of physical activity, regular meal consumption, the consumption of dairy products, and daily consumption. So this also take into consideration the weight, the dietary habits, and this is just the only what is required for the diagnosing of sarcopenia. This is a digital hand grip dynamometer, which you can hold the device firmly, squeeze the dynamometer as hard as you can, and hold and squeeze for the duration of test for around 3 to 5 seconds, and you can repeat it 3 times, and you will be able to assess the weakness in the grip. This is one study which we did at our center. I'm from Prayagraj, in the medical college. We evaluated 100 patients, and we found 63. We used the MR and measure the psoas muscles thickness to assess the muscle weakness. The psoas muscle index was calculated at the level of L3, and muscle strength was evaluated using the dynamometer. And we found around 65% of patients were having sarcopenia, and that was associated with the other complications, especially the diabetic neuropathy. So this is a matter of concern. This is just the study of the admitted and the OPD patient attending the tertiary care center. Now coming to the last leg, that is the management. So we have defined it, we have assessed it, we know there is a diagnostic criteria. Now how are you going to manage? The first and the foremost thing is already done. Now you have labeled them, you have advised them. Basic is strong recommendation. This grade 1 is the physical activity, resistance exercise. That's why I think exercise symposia, I'm not saying high energy exercise, the stretching exercises. You can use free weights, you can use dumbbells, you can use bands, you can do stretching exercises, you can do squats or skipping of ropes, whatever is feasible. This patient can be advised. You can just combine your aerobic exercise with some resistance exercises, and 3 days a week, and this may be preventive, and this is strongly recommended. So now another is there. I'll go into the details about the protein supplementation. Older need more dietary protein to prevent sarcopenia. This is around 1 to 1.5 gram per kg of protein intake is required. The pharmacology or the pharmacotherapy is not recommended as first line. Maybe there may be supplementation of omega-3 fatty acids, the role of vitamin D, role of vitamin C. So the data is insufficient. There are trials. I was talking about the myostatin inhibitors, the activin antagonists, some androgen modulators, tropon activators. They are in the pipeline. Going by one. So the balanced diet, yes, with the increasing, I think the NIN has given the plate system or the RSSDI diet recommendation, which has been given. A plate, wholesome plate is good enough, and we can choose a good quality protein of around 1 to 1.2 gram per kg per day. We need to talk about the sedentary lifestyle, because this has been responsible for frailty and sarcopenia. Prolonged periods of bed rest have resulted in 30% reduction in muscle volume. Resistance training, regular physical activity and exercise are crucial for primary prevention of chronic disease and reducing mobility in older adults. So combining resistance exercises and with protein ingestion has resulted in a better positive protein balance. So the interventions what we can do is advocation of physical activity early on, or so this improves the muscle sensitivity. Yes, this is a potent insulin sensitizer. It and preserves the muscle mass. So that is what we need to worry about. Maintenance of sleep. Now the bands are available. We are talking about the sleep hygiene. Yes, just reduction of smoking and alcohol, stress management, and obviously the probiotic and prebiotic have been talked. So I've just discussed about the effectiveness, the analysis support, but that is what we've talked about. Increasing the benefits of the resistance size and the recommendation. So we are very well aware about this. The balanced diet, the protein diet, we talked about the diet, the branched chain amino acids, particularly leucines, which helps to promote the muscle growth. So the consensus, as I told, they are not as a first line therapy, but yes, they are low certainty because they are smaller trials and there are biases also. So the recommendation, it should be considered. I will not say as a first line, but it should be considered to supplementing. Vitamin D, where there is deficient, should definitely be there, but there is still low certainty in telling that they have a causal association. So the pharmacological, no recommendation. Under the pipeline, growth hormone, ghrelin, myostatin, perintropin, lots of talked about, but we don't have. One thing which has been there in the literature is the branched chain amino acid leucine, and its active metabolite HMB is getting tremendous attention for its role in muscle strength and physical performance. The beta hydroxy beta methylbutyrate has shown to improve muscle mass, and this has been utilized in the patient. So there are certain literature, and this is the mechanism of action where the leucine is converted to HMB, and they are responsible for activation of mTOR and muscle protein synthesis. So this can be future, and this is an upcoming launch of Sarcoboost. This is Megamani molecule. They are in sachets, 3 grams, so maximum dose is 6 grams, which can be supplemented to your patients, and there are certain no side effects of it, and this is one of its kind, and to support muscle and prevent muscle loss. So the take home points are, so we have to make a schedule of a regular exercise, which is crucial in prevention. Again, I say prevention. The management is few. Protein intake is one, which should be balanced, should be with the leucine resources. Add on nuts and seeds, and they are good sources. Track your progress with simple tools, and now this is technology is set in, and they'll help you to assess. Supplements can help your journey, and stay consistent. That is what is more. The future perspectives we have discussed before, and so till then we need more of awareness, more of preventive strategies, where we can prevent sarcopenia, but do assess in all your patient. It doesn't take much of a minute. You can keep a hand held that digital dynamometer at your table. You can ask the patient, just pull it up. You can just time your watch. By the time patient comes from a distance of 6 meters, there's small test which actually can make you aware that this patient may have, by 65 years of we need to assess. But my point of saying in younger individuals also, be aware about sarcopenia, because they are physically inactive. Most of the corporate people are having a sedentary lifestyle, and that by the virtue of that, what is required at 60s, we are talking for 40s. Thank you.